Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the Heart of Healthcare podcast. I'm your host, Hallie Tecco, and today I'm talking to Dr. Vikas Saini, cardiologist and president of the Lown Institute, which every year produces the Shkreli Awards of 10 of the worst examples of profiteering and dysfunction in healthcare, named for the infamous pharma bro Martin Shkreli. The Lown Institute is an independent think tank based in Boston that advocates for a just and caring system for health. The Institute is best known for the Lown Hospitals Index for Social Responsibility, an annual ranking of U.S. hospitals that include measures like CEO pay, avoidance of medical overuse, and community investment spending. Dr. Saini, welcome to the show.
Thanks, Hallie. Thanks for having me.
Before we dive into the dishonorees this year, can you tell us more about yourself and the Lown Institute, which does more than just call out bad actors in healthcare?
Sure. As you pointed out, I'm a cardiologist. I went to med school in Canada, and then I trained in medicine at Hopkins and came to Boston to work with a guy named Bernard Lown in cardiology. And I didn't really understand what I was getting into when I decided to come here. Because Bernard, despite having invented the defibrillator with his team and, built coronary care units and being essentially present at the creation of certainly modern cardiology, was a very contrarian figure when it came to the use of technology in medicine, and instead wanted to minimize it. Our motto was do as much as possible for the patient and as little as possible to the patient.
I love that mantra.
Yes. And so with that kind of in our DNA and with a certain kind of advocacy and activism in our DNA, the Lown Institute has been working to sort of, I'd put it, to promote a vision of healthcare in America that's fundamentally different from what we have now, and much more inspired by his vision for really humanistic, relationship-based care in which the technology is second.
And at what point did you guys as a team decide that calling out bad actors was part of this mission?
I think we started the Lown Hospitals Index to do the opposite. We started it to find and then celebrate unsung heroes, hospitals that are doing things that are really hard, which is be good with quality outcomes, but also good on social responsibility. So that was our impulse. But I don't know if it's life, our current situation, or social media, whatever it is, there is a tendency to look at bad actors as well.
Yeah.
And in the case of American healthcare, it feels like there's been this ongoing drumbeat that seems to get, more and more notable and worsens every year. And so at some point, I think we decided to just take a look and start doing this. And the first time we did it, we were so overwhelmed, both with the level of interest, but also what we were uncovering. We realized, we should just do this as a regular thing.
And now it's become one of your most popular activities, whether you intended it to or not. I find myself, I call myself a healthcare optimist. I do feel like we have the right talent and people to really make change. And we're at this turning point in healthcare. But at the same time, it's hard to remain optimistic when you see bad actors and profiteers making things worse and seeing these articles all the time. And so I do feel like there's a balance, because we do need to hold people accountable and we do need to make people aware of the flaws in the system while still pointing towards the good, because there is a lot of good.
Yeah, I'm with you on that. I mean, I'm an optimist in the sense that by and large, people go into healthcare really for the right reason. Certainly at the provider level, it may be a little bit different, when you're talking startups and different types of, payers, all sorts of other stakeholders. But people do go for the right reason. And the reason for optimism for me is that there is a fundamental kind of irreducible element to the what happens in healthcare that is deeply human, and in that sense is the lodestar for a lot of people. The problem is it's all completely smothered in all this other stuff.
Yeah.
So the source of the optimism is that because people have that view and deep down have that feeling, that could be the start of something.
Yeah.
And in terms of what the Shkreli show, I think in some ways the awards, we're trying to really show across the board that there are problems in many sectors. There's no sector that's immune or that somehow has a halo.
Yeah. Yep. And there are all sorts of organizations on this list. So without further ado, let's start with number 10, which is Texas Medical School allegedly neglects to notify next of kin before selling body parts of the deceased. What happened here?
Who knew? There's a price discovery process for dead people's body parts. And you can now set those prices. And it's sort of amusing in a macabre way to put together all the different parts, and you may get the price of a human body, at least an inanimate human body.
What was that team? That team that was pricing this all to sell it. Can you imagine being in that room?
I think the thing is I don't know how this works, and they're not the only ones. I remember a year or two ago at Harvard, there was a similar kind of a scandal. And, I just think there's a market. There are people who are interested. And so the people who are interested, which includes device companies and other kinds of companies, I guess they poke around or they reach out. And if somebody's given the proposition, hey, you might make some money for your department, I guess
you have some assets laying around. Let's
monetize. That is the what's the word? That's sort of mission number one these days, right? Monetize whatever you can.
Yeah. Well, what struck me most about this case is how easily family members could have been contacted. This wasn't a challenge for them. They chose not to contact them and get any sort of permission or blessing.
Yeah, I think, it illustrates the ways in which financial incentives are never as machine-like, or financial incentives operate in a subtle way. And mostly they operate by greasing the skids in one direction than in another direction. Yeah. So it's not like they couldn't have reached out to the families. It's that in the scheme of things, it was just the path of least resistance, and the greatest sort of attraction was that way.
All right. Well, moving to number 9, Out of the Mouths of Babes, a taste for tongue tie cutting intensifies. And I want you to explain this, but first, this really goes against your mantra of doing the most for the patient and the least to the patient. What's going on with tongue tying?
Yeah, so this is a classic case of something that happens in medicine, in which, there is a condition that gets turned into a disease that then gets a treatment that takes off because, there's wind at your back in terms of the revenue and the financial side. And along with all of that, there's a, shall we say, vaguely plausible theory biologically that, maybe this is a problem. So, a small percentage of babies, the way the tongue is connected to the floor of the mouth is something that, is a variant. And in this case, the claim is that this is causing trouble with nursing, and then I assume secondarily with GI dysfunction, constipation, all these kinds of things. And so a surgical procedure, to free up the tongue is recommended and has been going like gangbusters. And apparently being
Is there
marketed,
ever an indication for it?
So far, the evidence on this is just not there. I mean, some people claim X, some people claim Y, and the evidence isn't really there. And that's kind of one of the problems with a lot of medicine.
All right. Number 8 focuses on Zynex Medical and their billing practices for pain management devices. And particularly striking, 70% of their revenue came from what?
Well, it came from the batteries and the sensors, a classic razor blade business.
Yeah.
It's what you want because, my current thesis is that everybody really wants to be a banker or a bondholder. They just want a monthly payout. And so subscriptions and all these kinds of things are the way to go. And a razor blade business is absolutely that. But in this case, given the trillions of dollars sloshing around in healthcare in general and in Medicare in particular, $1 billion here and $1 billion there, sometimes it just flies under the radar. In this case, people just got overloaded with batteries they didn't want or need. And on eBay, you can find all these excess batteries for sale.
Yep. Number 7, finally, we have a health plan. Cigna, who called an infant's emergency air ambulance, not medically necessary after the infant experienced severe respiratory distress after an open heart surgery, and it left the family with an enormous medical bill. Unfortunately, even with things like the No Surprises Act, we are still seeing cases like this. I mean, I don't know how you picked this one in particular because it feels like you hear these stories all the time about surprise bills.
Yeah. I mean, there are lots and lots of them. I think what this case illustrates is something paradigmatic about our healthcare system, which is that when we are the patient, we're left holding the bag. So the circumstances, it certainly sounds like this baby was in respiratory distress. It sounds like the transfer was necessary. I practiced on Cape Cod, and sometimes we were fog-bound when we had to send a seriously ill patient into Boston. And sometimes it was a coin flip, which was better, by land on ambulance or by air ambulance. So I don't know the details in that moment, that day, what the weather was, what all the other circumstances were. But you can be sure that mom and dad weren't the ones who insisted on an air ambulance. I think they took the advice that they got.
Yeah.
So this is really a case of the insurance company and the healthcare providers duking it out.
Yeah.
But a family with a newborn gets a $100,000 bill because of it. It's insane.
Already a family stressed with having a child with a heart condition.
Indeed.
To make it worse. Number 6 is about the Medicare catheter con. Tell us about this one.
Well, this is another dimension to our healthcare system. This, in some ways, has nothing to do with insurance companies, hospitals, doctors, maybe not even the manufacturers of urinary catheters. This is just out and out fraud. But basically, a few fly-by-night setups, somehow, I don't know how they managed, get a billing number, and they start shipping catheters. And when you look at the records, there are thousands and thousands of urinary catheters are shipped. And when the reporters investigating this went back to find the companies, they found one company, that was literally a storefront. There was nothing there. And the phone number rang at an auto body shop. So this is just pure fraud. but it is part of how our system can be gamed.
For some reason, I'm visualizing this in Florida. No offense, Florida, but I feel like that's where a lot of Medicare fraud happens. A lot of the
Florida is where a lot of stuff happens.
Yes, Florida is. Let's just leave it at that. All right. Yes. Number 5 is about private equity-backed medical center in New Mexico that faces allegations of refusing cancer treatment to patients and even demanding upfront payments from those with insurance.
Yeah. The whole role of private equity in healthcare, particularly on the provider side, is, warrants a whole conversation and a whole show itself. Generally speaking, these are not folks, who've managed healthcare businesses or at least, haven't been at the front lines of delivering care and the like. So a lot of, the management insights that they bring are really from the financial world it's straight out of, the movie Wall Street with Gordon Gekko. And, you buy an airline and you just got to trim the costs and do this and do that. And so almost certainly you can imagine in the back office, this is what was going on. But this is the real world consequence of what you see. And it's not, maybe they can justify it, but in the world of care delivery, it's hard to justify.
It reminds me of a friend who had to do emergency brain surgery in China. And before she went into the procedure, they had to get together a red envelope with cash in it for the surgeon before the procedure. These are it's not too far off.
Well, I can tell you in India, I was told when somebody's in the operating room having an operation, this is in a big city in Bombay or Mumbai, before the scalpel cuts the skin, the bank account of the referring doctor has been credited. So there's a lot of sort of kickback stuff going on. And on the provider side, in this country, we haven't gotten there, but there are more subtle and sophisticated ways in which kickbacks and various things happen.
Oh yeah, they're called marketing fees. They'll name them creatively to get around being considered a kickback. It happens.
Yeah,
it happens. Number 4 is particularly disturbing. It's about a specific Montana physician, not Florida, Montana, a high-earning cancer doctor with a pattern of patient harm. Tell us about all of his nefarious activities.
Well, this was an incredibly long investigative piece in ProPublica. And it was, I think the reporters spent, a couple years on this. And the kinds of things that were reported included, in one case in particular that seemed very egregious, a lot of chemotherapy, which is very expensive and repetitious, which generates a lot of fees and a lot of revenue.
Yep. We talked about they like that recurring revenue.
Yeah, absolutely. And in this instance, review of the biopsies and an understanding of, that person's underlying condition failed to confirm that they even had cancer. There are other instances where, towards very end stages of life, quite often things were hastened without the right conversation, without the right understanding, or even the appropriateness of that action. So it's a long story. Yeah. As a physician, for me, what it underlines is that there's a huge amount of trust and an honor system for the practice of medicine. And betraying that trust and violating that honor system has huge consequences. It becomes effectively a threat to the whole ethical demeanor of the profession. And the profession hasn't done a very good job at policing itself.
Yeah.
We say we will. There are a few structures in place, but study after study has shown that, Board of Registries of Medicine in all the different states. It takes a huge amount to actually get someone seriously disciplined.
Yeah.
And I think the question of how we monitor the appropriateness and all of that of care is now an open question. And that's because the medical profession has fallen down on the job of peer counseling and peer review of these things.
Well, on the same note around cancer drugs, but we have number 3, which is the first pharma company on this list, is Amgen's dosing strategy, being more driven by profit than patient need, and the cancer drug Lumakras. I don't know if I'm pronouncing that correctly. So tell us about this practice and how common it is to be pursuing this like maximum tolerated dosage strategy.
Yeah, so I'm going to cut him a little bit of slack in the sense that anybody who's developing a therapy, the bias in our system is to find out if it works, not to find out if it doesn't work. To find out if it works, you got to be sure you're using an amount that is really going to have an effect. And so in preclinicals and all those early phases of trials, and then even in the phase 1 trials, where you're trying to understand what dose is toxic, not necessarily what dose is effective. But your job is to figure out what's the upper limit of what isn't toxic. Once you find that out, there's no incentive to say, okay, well, let me use a much lower dose. It might work. You want to use the dose that'll work. And so you're going to crank it up. And that's what happened in this case. And when the FDA reviewed it, there were some questions about whether the lower dose might be adequate. So then they did a repeat study. And in the repeat study, and I found this interesting. In fact, I have a mind to, write them a letter because I'm just curious about this. In the repeat study, they say it showed better results on outcomes. But when you look at it, it's better results on the point estimate, but the confidence intervals, widely overlap. It could have been noise, the play of chance, but they seem to have grabbed it and they're, sticking by it. It's better, they say. And we don't really know that. And so the approval from the FDA, despite this trial, is for the higher dose. And I think it illustrates a lot that's wrong or needs fixing at the FDA, and whether the new incoming chief, Dr. Marty McCary, can address that, I don't know, but I would hope so.
Yeah, he's a smart guy, so hopefully he can. All right, so number 2, it is no surprise that UnitedHealth made this list somewhere for a whole slew of misdeeds. Which grievance is it that made them get on the list?
This is primarily the question of upcoding, which is billions of dollars for the taxpayer to pay and billions of dollars of revenue for them and other companies, I should point out. And so the story here is that when people go from Medicare, traditional Medicare, to Medicare Advantage, the government pays the insurance company that's administering the Medicare Advantage product on the basis of how sick the patients are who decide to go there. And the way they measure how sick they are is all the different diagnostic codes, and they calculate this into a risk score. And the higher the risk score of, the tens of thousands of patients who are in your plan, the more money you get from Medicare. So in this instance, United had a really efficient system of generating lots and lots of diagnostic codes on these patients. So their argument would be, in order to provide better care, we must know everything the patient may have, but also in order to get fairly compensated for all the extra conditions that this patient had. The problem is, of course, that when you do this on an industrial scale, the very meaning of having those conditions starts to get diluted. And the risk scores probably are meaningless. But man, it's worth billions of dollars, and that's what they did.
Yep. All right. That leaves us with number 1, the Steward Health Care bankruptcy and Wreck-It Ralph.
Yeah. So Ralph De La Torre, a cardiovascular surgeon, started this journey here in Boston at the Beth Israel Deaconess. He was a good surgeon and a very good manager of the business of cardiovascular surgery, so much so that he rose rapidly into leadership roles. And then at some point, in part because of a lot of back and forth with the Catholic Church and the settlement on some of their claims and the need for liquidity, Catholic hospital system, Ralph was asked to lead it, and it went on this journey, which started out as a value-based care journey, started out as an accountability journey. Let's really deliver better care at lower prices. So it sounded really good, but over time, and I wasn't privy to any of this, but over time, the mission crept into growth for growth's sake, expansion for expansion's sake. And at some point, somebody I know who was close to that, the inner workings there, said, Vikas, this is a real estate play. This is not a healthcare play. And then when you start examining what started happening, it was very clear it was a classic leverage buyout of the 1980s kind of a scheme where you load up the enterprise with massive amounts of debt. The debt that, brings in all this cash that you've borrowed, you pay yourself and shareholders special dividends, not even on a regular basis, but a one-time blockbuster payment.
Yep.
And then the enterprise is saddled with this debt that it has to service with its revenue. And effectively what that means is it has to pay debt by cutting corners. And cut corners they did, at least here in, I don't know about the rest of the country because they grew all over the country. Yeah. But here in Massachusetts, I've heard stories of nurses bringing in their lawnmowers so they could mow the lawn at the hospital.
Oh my gosh, what?
Because they were tired of looking at it.
Wow.
And that's not the worst of it. There were key supplies missing in emergency rooms and ORs, and it led actually to people's death. So
while prices were rising.
Yeah. So this is like everything wrong with, putting profits before patients, I guess is how you'd have to put it.
Yeah. Yeah. Well, we saw on this list, there were nonprofits, for-profits, private equity, public companies. So, I think good can come from anywhere and bad actions can also come from anywhere. So question for you, have any of these bad actors over the years reached out to you to accept their award?
Several have complained that we didn't get the story right.
Even though you're just reporting on another story.
Exactly.
Yeah.
Exactly. Or they'll say, the reporter didn't get it right. Several will say there's a lot more to it than that. You're missing the nuance, and we may be.
Yeah.
But nobody has, flat out denied, what's been going on.
Sure.
So one of the things that these Shkreli Awards show us, as we said at the start, is that you can find dysfunction practically everywhere you look in healthcare. Yeah. But the other part of it that I think is a silver lining is if you analyze these cases across the different domains of healthcare and analyze them carefully, it's almost like you begin to see a blueprint for what you need to fix. And if you fixed it all, we'd have a very different healthcare system. The problem is there's nobody in charge to fix it all. It's fragmented. A lot of people think the market is going to fix this, but this is, these problems are structural and systemic, and they exist outside the bounds of the market in many ways. There's a fundamental question about what is happening in, when you're doing healthcare, what is actually this thing that's happening? Is it a commodity? And if so, what kind of commodity? So for example, take your car in and you have the muffler fixed and there's a spare part and there's there's the skill of the mechanic. You pay a bill. There's a market. You look at who is cheaper, who isn't. You need your knee replaced. There's hardware. There's a guy doing it. You can try to see what the market is like. But even in that best case, it's not the same. The emotional dimension is different. The nature of the relationship to your own body and your health is very different from your car needing a muffler. So it's
and there's
really
no middleman in the car. You go straight there. You're not dealing with a intermediary who's telling you who's in network, who's out of network, and making the prices so inconsistent.
Yeah. And so, I think there are deep philosophical debates to be had here about the nature of what this is. If it's a procedure, you can make the case, though I would argue even in the case of knees, a knee replacement, it's not quite the commodity you think it is. But a lot of healthcare is not that. And the real problem is what we value, what we all value, what we as a society should value is not the procedure, but health, but well-being. And the problem with well-being is there's not a discernible, bounded product that you can put a price on and commodify and run in a market-based system. Because in fact, there's the ROI on that is diffuse. We all benefit if we got a healthy society. The best case you might make is government maybe is the only entity that can realize the full ROI because it takes 5 years, 10 years for health to really start showing up in productivity.
Exactly. Productivity, work absenteeism. There are a lot of ways that our economy benefits from health.
Yeah, but the problem is it's not direct and it's not fast enough.
Yeah.
And even in the case of governments come and go, politicians come and go. So the guys and gals making policy today, aren't going to be around in 10 years when the results come in. And so it's a serious dilemma.
So to end on an optimistic note, what gives you hope that we can address these issues and that eventually the Shkreli Awards will be unnecessary?
Well, what gives me hope is that we're human beings and healthcare is fundamentally about that. There's a lot you could say about AI and technology and what's coming. I tend to be a techno optimist, though I think right now the AI stuff is way overhyped. And that's a whole other conversation. But in general, because of that fact, that irreducibility of the sort of human connection, we're going to have to get it right. It's just not going to go away and it's not going to disappear. Yeah. And if it doesn't disappear and people have to face it over and over, we will get it right.
Well, Dr. Saini, thank you so much for joining us today. And thank you for the great work that you're doing.
Thank you.
And to our listeners, the Lown Institute also presents the Bernard Lown Award for Social Responsibility, the Blazer Award, which honors young physicians demonstrating bold leadership in social justice, healthcare reform, environmental justice, global peace, or other humanitarian efforts. You have until the end of January to nominate someone for this award. The link is in the show notes. We'll see you next week.
Thanks, Hallie. Thanks for having me.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.